even starting, which is the ultimate goal, right? So we're going to talk about Alzheimer's disease. And I think a lot of lay people are confused about the difference between Alzheimer's and dementia. Well, dementia is the basket term or the umbrella term for all neurodegenerative diseases that cause a cognitive decline. Alzheimer's is the most common form of dementia. It's not a normal process of aging. However, if we all live till above 100, eventually we would all get it because the brain just wears out. It's a progressive loss of intellectual abilities that eventually interfere with daily living, and it interferes with your ability to be independent, and it's the most common cause of dementia. I'm going the wrong way. So, a brief outline, we're going to sort of follow it. We'll talk about the symptoms, then causes, then show you how we go about making a diagnosis, treatment options, which we'll go into detail with, and finally, hopefully, we can give you some clues as to and tips as to how to prevent you from getting it. So, you can look at dementia as an umbrella term used to describe a range of symptoms associated with cognitive impairment. And to the right, you'll see the most frequent forms of dementia. We'll talk not only about Alzheimer's, but we'll also touch on vascular dementia, Lewy body dementia, which are the two more common forms of dementia after Alzheimer's. And then there's rarer forms like frontal to temporal dementia. And probably the second most common is actually mixed dementia, because you can have Alzheimer's plus vascular, Alzheimer's plus Lewy body, and Alzheimer's plus multi-infarct dementia, which we'll also talk about. So, this is just another slide telling you what it is. It's progressive and disabling, and it's different from normal cognitive lapses, which I call normal lapses as we get older. Everybody becomes a little bit slower. I myself, as I've gotten older, feel that I've lost some processing speed. You know, things just don't come back to me as quick as it normally does. Like when I watch Jeopardy, I know the answer, but I just can't say it, or it doesn't come out. And not like 30 years ago. So that's how, but that doesn't mean you have dementia. Occasionally you have normal lapses, like on the left, but dementia is more severe. And here's more examples. Forgetting a name, leaving the kettle on, finding the right word, like I said. And dementia is not recognizing a family member, using inappropriate words, and getting lost in your neighborhood. Now, dementia can be both reversible and irreversible. Alzheimer's disease, frontal temporal dementia, Lewy body, they're all irreversible. But when I see people, one of the first things I try to say is I try to find a reversible cause. And we try to find something that's treatable. So these are the frequent things that can look like dementia. You look for urinary tract infections or any kind of illness. You look for medication side effects. I can give you an antidote. I assumed the care of a person from another neurologist, and she had epilepsy and was on medications, and the epilepsy was controlled, but she began to have cognitive problems, and she was diagnosed with dementia, Alzheimer's disease. And I followed her for a couple of years, but then I realized she's not getting any worse. So I looked into it further, and I did another cognitive test, and she was almost back to normal, but not quite. So I looked at her medications, and I stopped, and I changed one of her seizure drugs to a different drug, and she was back to her normal self. And so we were able to say that she wasn't demented, and she really didn't have Alzheimer's. It was the medicine that was causing her issues. And then there's something called delirium. Delirium is not something we see so much in the office. It's something that occurs mostly in the hospital, and it's because of an acute illness, like an infection or kidney issues or liver issues, and that's reversible. So we'll try to treat that. We also look for thyroid imbalance, and it's also very important to make sure that when we evaluate people, that we make sure that their hearing and vision are as good as possible. Because certainly, isn't it natural to think that if you can't hear well or your vision's not good, you're not going to be as sharp, and you're not going to convey that to your examiner, and it'll look like you're impaired, when actually all it is your vision's not as sharp, or you've lost your hearing. So I always make sure that when I evaluate people, that I make sure their hearing is as good as possible, and they get hearing aids if they need to, and they have their vision checked. It's also important that sleep disorders can really mimic or worsen a cognitive decline. And so one thing I ask about is to check your sleep history, particularly if you have something called obstructive sleep apnea. That can really increase your cognitive decline. And then there's a condition that's sometimes frequently mistaken for dementia called normal pressure hydrocephalus. That's a condition where there's three aspects that present. One is a cognitive decline, the next is a gait disorder, and then the last thing is urinary incontinence. So if you have 2 out of 3 of those, you think about that, and that's a treatable disorder that's caused by too much spinal fluid accumulation in your brain, and it results in putting pressure on your brain and causing those 3 things: cognitive decline, gait disorder, and urinary incontinence. And that can be treated with a neurosurgical procedure where they place a shunt in your brain and drain the fluid, excess fluid from your brain, into your abdomen. And people do remarkably well. And finally, you want to make sure they don't have a tumor. So this is delirium, and it's acute. It's not like dementia, which is a gradual, insidious onset. Delirium happens acutely. So that's why it typically occurs in the hospital. Now, the other thing we think about is depression. We always make it a point to do a short depression scale, because people who are depressed can look like dementia. Here it is again, it's acute onset. It happens over hours to days. And finally, depression. One of the tips I find that from people with depression is that a depressed person is more likely to seek me out than somebody with true dementia. They're worried about their memory, and they actively seek you out. But when you evaluate them, they sort of don't perform to their best ability when you examine them, and they don't cooperate with your testing. And you find that they're depressed, and you'll see that I send them to a psychiatrist, they get put on medicines, and they wind up doing much better. Now, we come to mild cognitive impairment. You don't go from being a normal person to being demented, right? It takes most people several years for that to happen. And that transition phase is called mild cognitive impairment. It's in most cases, it winds up, you could call it early Alzheimer's. But some people, and I have a couple of people that I follow, do not progress to Alzheimer's, but they're far and few between. It can take anywhere from as much as 5 years. But most people, if you follow them, they will convert at a rate of about 10 or 15% a year. So when you push that out to 5 years, more than 75 or 80%, after you test them again, have progressed to Alzheimer's disease. So initially, like in mild dementia, all you have in the beginning is that you have some inefficiencies in your activities of daily living. You know, you forget an address, you make a little mistake in a checkbook, but it's nothing severe. You're still cognitively intact, and you can do most of your activities of daily living without a problem. But then, as the years progress, those inefficiencies get worse, and you become eventually incapacitated. So you converted about 5 to 15% a year, and so 50 to 80% have converted at the end of 5 years. But there are a lucky few that never progress to dementia.